Welcome to today's ADEA webcast titled The Dental Safety Net and Access to Oral Health Care. It's now my pleasure to introduce our host, Dr. Eugene Anderson, who is the Chief Policy Officer and Managing Vice President of the American Dental Education Association. He leads the ADEA Policy Center. The ADEA Policy Center provides evidence-based research and analysis, collaborative advocacy, and thoughtful leadership. The ADEA Policy Center works through 4 targeted portfolios, including access, diversity and inclusion, advocacy and government relations, educational research and analysis, and institutional capacity building. We are pleased that Dr. Anderson could join us and host today's webinar. Dr. Anderson, welcome to the program.
Thank you, Kurt. We are fortunate to have 3 public health experts join us today to share their expertise regarding the nation's struggle to ensure comprehensive and continuous oral health care to all segments of society. First, we're joined by Dr. Lou Lemperis, who is Clinical Associate Professor in the Department of Dental Ecology and Director of the Dentistry in Service to the Communities program at the University of North Carolina at Chapel Hill School of Dentistry. We're also joined by ADEA's very own Dr. Evelyn Lucas Perry. She serves as the ADEA Director of Public Policy Research. Lastly, we are fortunate to have with us today Dr. Chris Halliday, who is the inaugural Dean of the Missouri School of Dentistry and Oral Health, which is A.T. Still University's new dental school located in Kirksville, Missouri. Thank you to all of our experts and to all of our participants for joining us today. Again, I will be your host this hour, Dr. Eugene Anderson, ADEA Chief Policy Officer and Managing Vice President. In today's webinar, our participants will hear directly from these experts on how to identify the systematic barriers that individuals, communities, and populations face when accessing oral health services and the current measures used to define this problem. Secondly, we'll describe the complexity of the dental safety net and its role in providing care to the underserved. And finally, the webinar will explore the role of the academic dental institution in the dental safety net. Back in 2007, not too far from the ADEA offices here in Washington, D.C., Diamante Driver, a 12-year-old boy from Prince George's County, Maryland, died from a preventable tooth infection that spread to his brain. The tragedy brought much-needed attention to the lack of access to oral health care and highlighted the rare but extremely serious potential consequences of untreated dental disease. So now, 7 years after Diamante's tragic death, where does this country stand as far as access to care and how we measure this access? So let's turn to one of our experts. Dr. Lemperis, how are we doing in the U.S. on access to oral health care?
Thank you, Dr. Anderson. I really appreciate that introduction. I thought I'd begin my portion of the presentation utilizing Healthy People 2020 as a guidepost. As you know, Healthy People 2020 provides a comprehensive set of 10-year national goals and objectives for improving the health of all Americans. There are over 42 topic areas with over 1,200 objectives. Of these 1,200, 26 have been identified as leading health indicators, and these have been identified to help communicate high-priority health issues facing our nation. For the first time in the history of Healthy People 2020, the first time of Healthy People, an oral health objective has been selected as a leading health indicator, that being the percentage of children, adolescents, and adults who visited the dentist in the past year. The target is to have 49% of the population greater than age 2 to have an annual dental visit by 2020. It's important to realize that there are a range of personal, social, economic, and environmental factors that contribute to individual and population oral health. These factors, referred to as social determinants of health, result in significant disparities among groups of individuals in their ability to access oral health services. For example, as seen in this slide, among adults 25 years old and older without a dental visit in 2011, the rate for those with less than a high school education was nearly twice that when compared to those with at least some college. Later on in the presentation, I'll be highlighting some of the other disparities that are specifically related to race, ethnicity, and socioeconomic status. As of this past March, oral health is one of 3 indicators that is moving in the wrong direction. From 2007 to 2011, the percentage of persons aged 2 years and older who had a dental visit in the past 12 months decreased by about 6%, from 44.5% to 41.8%. As a nation, we appear to be headed in the wrong direction. Taking a closer look at the data, in this case breaking it down by age cohort, one gets a bit more clarity regarding this access measure. Among children ages 2 to 8, as we see in the top of this graph, there appears to be an upward tick. Among those 65 and older, the green line, access appears to be increasing. We don't know why this is the case. What is most disturbing, though, is the downward trend for those between the ages of 19 and 64, the blue line. As you can see, in 2003, the number peaked at 41% and has dropped to 36.1% in 2011. As shown in this slide, when people are directly asked when they last visited the dentist, as is done through the National Health Interview Survey, the data are not as alarming as those I've just shown using the Medical Expenditure Panel Survey, also known as MEPS, the data source for Healthy People 2020. But I thought it important to include this graph as it highlights one of the many challenges we face when we try to get our arms around the issue of access to dental care. That being, how do we best measure it? MEPS data is considered the most reliable because it includes not only interview data, but data collected from medical providers, pharmacies, hospitals, and third-party payers. In looking at this slide, though, one sees similarities in terms of trends over time to those seen in the previous slide. Among children, looking at the blue line, access appears to be increasing, whereas those between the ages of 21 and 64, the red line, there is a downward projection and trajectory. I suggest, perhaps, that another way of looking at access, in this case for children and adolescents, is to see how many of our nation's children have benefited from having had a dental sealant placed, an evidence-based preventive intervention that requires that a child has access care from either a dentist or a dental hygienist. Here are data from the 2009-2010 National Health and Nutrition Examination Survey. What we see here at the top of the graph in green is that among 6 to 9-year-olds, only 32.1% of the children have had a dental sealant placed. The second green bar shows that just over half of the children between the ages of 13 and 15 have had a dental sealant placed. When we dig down into the data, though, we begin to see that there are significant health disparities. Among 6 to 9-year-olds, 35% of non-Hispanic white children have had access to dental sealants compared to 27.3% of non-Hispanic black children and 26% of Hispanic children. We go on to see similar disparities in access to these preventive services for the older cohort and also by poverty level for both groups at the bottom of the slide. Here's another disturbing trend, which has caught the eyes of policymakers and continues to make headlines across the country: the increasing number of individuals who are utilizing hospital emergency departments to access oral health care. In looking at this slide, the top line represents a doubling in the percent of emergency department visits as a percent of total visits for those between the ages of 21 and 34 between the years of 2000 and 2010. Again, in the line below, a doubling for the same time period for those between the ages of 35 to 49. The trend is disturbing. Is this another indicator that there's a growing access to care problem in the United States? I'll let the listeners decide. In this next slide, when people are asked if they encountered barriers to accessing dental services when they had need for dental care, once again, we see that those between the ages of 21 and 65 appear to have the greatest problem. These data indicate that there's less of a problem when it compares responses received from 2011 to 2012, those in teal compared to those in 2003, 2004, those in purple. Again, the caveat is that these are self-reported data, but we do see trends across time, as seen in the other slides. When people are asked why is it that they did not access care, the major reason identified is that the cost was the principal barrier. This was followed by not having dental insurance. Other surveys indicate that the primary reason for not obtaining dental care has more to do with the individual's perception about their own oral health status. That is, they don't need to see a dentist because they're not experiencing a problem or their mouth is fine. Again, although we get different answers from different surveys, the bottom line is that many people are not accessing dental care routinely. As we all know, there is a debate going on as to whether there are enough dentists available to address the oral health needs of the nation and whether the pipeline is sufficient to meet future needs. Some reports say that there are more dentists retiring each year than there are dental school graduates to replace them. Others say that there are enough dentists to provide care, but they're not located where the need is greatest. This map shows dental health professional shortage areas as designated by the Health Resources and Services Administration. There are different types of HFCS designations, each with its own requirements. Geographic areas, which are based on population to dentist ratio, or population group designations, for example, the percent of the population on Medicaid as it relates to the number of dentists in the area. Is this one measure an accurate way of determining whether there's an access to care problem? I don't believe it is. But based on the data I presented so far, I'd say that there is a preponderance of evidence that indicates there is a significant access to care problem in the nation. I know that Dr. Halliday in his presentation is going to dig deeper into this data specific to Missouri, which is kind of centered in the map, and there's a lot of purple in that area. In this next slide, and these next few slides actually, I'm going to be talking about the Medicaid program and the impact of the Affordable Care Act on that program. As seen here, there's significant variation among states as to the scope of services covered for adults provided by state Medicaid programs. Some states, those in green on this map, offer robust plans for Medicaid populations. Others offer a limited scope, those in teal. Others only emergency services, only in purple. And some don't offer any adult benefits, those in orange. One caution about the slide is that these data are from December of 2013, and some states have recently reinstated or expanded the scope of services provided to adult beneficiaries. This morning, for example, there was an announcement that the state of South Carolina is now going to start covering adult services starting December 1st. It's a constantly moving target. That's what I want to point out, though, which unto itself can be a problem. In order to improve access to care, not only is it important for state Medicaid programs to offer a robust scope of benefits, it's equally important that fees paid by state agencies will assure that providers, be they in the private sector or the public sector, are reimbursed at rates that will allow them to meet expenses. Again, as you can see here, there is wide variation across states as to how state Medicaid rates compare to those offered through commercial plans. As one of my dear friends who works in the community health center once said to me, Lou, if there's no margin, there can be no mission.
Excuse me, Dr. Lempiris, I have to jump in and ask a question. Since we're talking about Medicaid, isn't the Affordable Care Act supposed to increase the number of individuals eligible for the program?
Yeah, it certainly is. And as you look on this slide here, it's been calculated that more than 8 million adults could gain dental benefits through Medicaid expansion. as a result of the Affordable Care Act. But, Dr. Anderson, what does that mean, though, in terms of access to care? Will there be enough private practitioners out there willing to take Medicaid patients into their practices if there's an increased demand for care for those who are now insured through Medicaid? Will the safety net be able to provide care to this expanded group of beneficiaries? Will the reimbursement rates be sufficient to attract providers? Will this increased demand create a demand for new types of providers? And what will the impact be on our dental academic institutions? I don't know the answer, but I think these are the questions we must all be prepared to answer. I hope I've set a table for the rest of the presentations that are going to follow and trying to paint a picture for everyone.
Thank you, Dr. Lamperis. That was quite insightful. A very good job setting the table. Your overview of where our nation stands regarding access to dental services leads us to wonder, where are dental services being rendered for vulnerable and underserved populations? Dr. Lucas Perry, can you tell us from your research, where are dental services being rendered for these vulnerable and underserved populations?
Absolutely. Dr. Anderson, that's a great question, and it really leads in nicely to describe the dental safety net. But before I begin to discuss the complexity of the dental safety net, let me begin with a visual analogy. So if our participants can look at their screen, this is really my attempt to visually articulate the systemic and persistent barriers that millions face when navigating the oral health delivery system for basic and routine dental services. So in addition to, as Dr. Lamperis spoke about earlier, the high cost of dental care, individuals and families may experience language and cultural barriers, transportation challenges, difficulty with work and child care arrangements to attend dental appointments, lack of dental providers within their area, or the lack of dentists unwilling to accept their insurance. So to understand the dental safety net, to understand the current oral health care system, I really appreciate the description in the Institute of Medicine's 2011 report titled Advancing Oral Health in America. And the report defined two primary access points for oral health services in the United States. The first being the private delivery system, and then the second being the dental safety net. So the two systems largely function independently from one another with different patient populations, practice settings, and financial streams. So looking at the before we look at the dental safety net, just to key in on the private delivery system, it's really composed of individuals with either employer-sponsored health insurance, so these are individuals who are insured, or have the ability to pay for dental services out of pocket. And the care that's usually rendered is happening and occurring in the private dental practices. But before I go into the dental safety net, I do want to get our audience a little engaged. And so I'd like to ask them and get them to give us their responses in terms of how many Americans access the dental safety net. And as you can see, we have four answer choices. So if you could go ahead and indicate if it's 7 to 10 million, if it's 7 to 8 million, 10 to 12 million, 20 to 25 million, or 30 to 40 million.
And we'll give everyone just another 5 seconds or so to complete that process, and we will then stop the poll and share the results. Please make your final selections. Thanks much for participating. And at this point, the results are shared.
Okay, so I see that the majority thought that the dental safety net was able to provide care to 10 to 12 million annually, and actually, unfortunately, it's less than that. It's the lowest that's listed. It's the 7 to 8 million. A study by Baylett and colleagues in 2006 estimated that the capacity of the dental safety net was only 7 to 8 million. So when we're speaking about this dental safety net, it does give the illusion that the word itself, safety net, you think, of course, it's supposed to be a comprehensive way of providing care, but in fact it isn't. The dental safety net has a lot of different entities that are involved, and as described earlier by Dr. Lampiris, as far as the Medicaid population, it really depends on the resources within the state and sometimes also what's happening in the local community. So to get an idea of the dental safety net, it's really a multitude of different entities that are involved, such as private practice dentists, federally qualified health centers, mobile vans and dental units, a local health department. And so all of these different entities have some type of influence on the dental safety net. When I described earlier the private care delivery system, and I also said that a lot of that care happens in private practice offices, it is important to note that private dentists also have a role in the dental safety net through charitable programs such as Missions of Mercy or offering discounted services within their practices. And while I'd love to spend the entire portion of my presentation or this hour talking about the different entities, I'm going to focus on a few. But I just do want to note that this is not an exhaustive list. It really, like I said, depends on the resources that are available within that community or within that state. So first, I'll focus on the federally qualified health centers. So when you hear FQHCs, this is what they're referring to. This is the acronym. And the idea behind the federally qualified health centers is that they're really embedded within the communities that they serve. So first, they have to be located in underserved areas, and they provide both primary and supportive services. So supportive services are not necessarily actual care that's being delivered, but again, going back to the barriers that I described earlier, such as linguistics or transportation services, there's the ones that coordinate and really try to eliminate those barriers to care. In addition, federally qualified health centers, the majority of their governing board has to be patients that they actually serve. And so that's very notable, again, to highlight the fact that they really are supporting the community. Additionally, federally qualified health centers, almost 9 out of 10 of the individuals that are cared for are below the federal poverty line. And to put this into perspective, in 2014, the federal poverty level for a family of 4 was approximately $24,000 a year. Again, $24,000 a year. So they operate usually on a sliding fee schedule. So it depends on what the individual makes, and that's how much they would pay, if any, for a service. So there's about 1,200 health centers, and they serve approximately 20 million people. And of those 1,200 health centers, 820 health centers provide some type of dental service, and it could be just referrals all the way to comprehensive services. Now, they are responsible and they must provide preventative dental services to children, but it doesn't have to happen in-house. It can be a referral system. And so, you lose that. Again, presents another challenge, another barrier as far as access to care. So speaking of that, when you're talking about children, that leads in nicely to the school-based oral health services. And so this can include fluoride programs, sealant programs that are largely have a large involvement from our dental hygienists. But right now I'm going to focus on school-based oral health centers. So these are actually centers that are located within a school, and they have served nearly 800,000 children. And while they're mostly located in urban areas, 27% are located in rural schools. So there's about 1,900 school-based health centers. Unfortunately, only 10% have the capacity to provide comprehensive dental services. But again, these school-based oral health centers really support the school and respond to the needs of the community and eliminate a lot of barriers in terms of parents having to take off of work and for children to get access to care. The other one here at ADEA, of course, that we're very much interested in is the role of academic dental institutions. And they play a significant role by serving as a dental home. So they provide comprehensive care for vulnerable and underserved patients. For instance, the Medicaid population, the dental institution is often the largest Medicaid provider within the state. In addition to basic and routine or emergency services, academic dental institutions play a role for specialty services, such as root canals or oral surgery through their advanced education dental programs, and then also referring for hospital-based services that are needed. And then the other thing is that dental schools have a distinct responsibility for educating dental students and dental hygienists that are competent to meet these changing demographics within our society. So that's making sure that they understand the ethnic and racial composition and responding to the needs of the aging population and the special needs population. I just do want to focus on the fact that, I didn't have a chance to go into all of the entities within the dental safety net, and again, it is a fluctuant system. But regardless, the community that's being served is really hanging on by a thread. It's the misconception that the dental safety net is working, and it really is something that needs further investment. So with that being said, there is a positive note to this, and that is the critical investments that the Affordable Care Act is making. I've listed several, but I'm going to focus just on a couple right now. So the $11 billion for the Community Health Center Fund, so that is where federally qualified health centers receive their funding. And so there's an $11 billion investment over a 5-year period. And while this isn't just directed towards dental care, it should and be able to increase the infrastructure for all comprehensive services, including dental services. The other one I want to focus on is the $1.5 billion for the National Health Service Corps. So that's providing funds for primary care providers, including dentists, to work in underserved areas through scholarships or loan repayment. The last thing that I want to note is that the Affordable Care Act and also all entities that are involved in providing care are really looking towards a comprehensive system. And within the comprehensive system, it's the idea that there's going to be what's called a patient-centered medical home. And so the idea behind the patient-centered medical home is that it expands beyond the dental home, which is, of course, focused on comprehensive, coordinated, and patient-centered care for children, as defined by the American Academy of Pediatric Dentistry. It builds upon that to have a comprehensive system for all types of care. And the idea is to make sure that it's patient-centered, that it's coordinated, it has accessible services, and it's focused on quality and safety. And so I hope, Eugene, that does give a pretty good example of the complexity of the dental safety net in addition to how we're moving forward with policy, but again, the need to have further investments to increase access to care.
Thank you, Dr. Lucas-Perry. We have a question from one of our participants seeking clarification on one of the slides, specifically the one on federally qualified health centers. And the question is, does referral to an outside provider fulfill requirements for preventative services?
Yes, so it doesn't necessarily mean that the service has to happen on site. And so again, that's where you're losing a lot of patients, is that referral service. So they have to have a referral system in place, but the care doesn't actually, they don't have to make sure that the care is necessarily rendered.
Thank you. For our other listeners, feel free to type questions you have into the chat box. We will have an opportunity to answer several questions near the end of our hour, but we will also answer some questions throughout the hour. And for any listeners who have recently joined the call, welcome to today's webinar from the American Dental Education Association. Our title is The Dental Safety Net and Access to Care. It's being presented by the ADEA Policy Center, which supports ADEA's role as the voice of dental education. My name is Dr. Eugene Anderson. I'm the ADEA Chief Policy Officer and Managing Vice President. To learn more about the ADEA Policy Center, we encourage you to go to the ADEA website, www.adea.org, and click on the Policy tab. We're joined today by 3 experts on this topic, Dr. Lou Lamperes, Dr. Evelyn Lucas-Perry, and Dr. Chris Halliday. And now we're going to pause for a moment to take a participant poll to see just how many people are with us.
And we have options of 1 through 8 or more, so if you happen to have a group attending at your site, what we'd like you to do is click on the 8 or more option, and we'll give everyone just another 10 or 15 seconds to complete their responses. We want to thank everyone for participating in this poll, as well as the first one. And just a reminder, as mentioned, we do welcome questions or comments through the general chat. And at this point, it looks like the responses have pretty well tapered off, and we will go ahead and stop that poll, and we can return back to the presentation. Dr. Anderson.
Thanks, Kurt. So a few moments ago, Dr. Lucas Perry described the entities involved in the dental safety net, particularly the critical role of academic dental institutions. So now we want to turn to Dr. Halliday. And this is a great opportunity for you to share what initiatives are occurring at Missouri School of Dentistry and Oral Health, AT Still University. Dr. Halliday?
Thank you, Eugene, and thank you, everyone, for joining the call today. The state of Missouri has significant challenges for access to oral health, and there are also tremendous oral health and overall health disparities experienced by communities within the state. Missouri has ranked towards the bottom of all states in the percentage of adult residents who visit a dentist annually. And in many of the communities within the state, both in urban as well as rural areas, the percentage of adults who visit a dentist annually is much lower than the state average. Whether it's a lack of dentists or it's a maldistribution of dentists, the fact is that access to oral health care is a problem for many of the citizens of the state, and that's whether they reside in rural or urban areas. The state lags far behind the national average in the number of dentists per residents. Missouri has about 63 dentists per 100,000 residents compared to a national average of approximately 78 per 100,000 residents. In the state of Missouri, there are more dentists leaving full-time practice each year than there are new graduates entering practice within the state. Dr. Lampiris earlier brought up dental HIPSA designations, and take a look at this slide. But 101 of the 114 counties within the state of Missouri have been designated by HRSA as being dental health professional shortage areas. It's been estimated also that 250 additional dentists would be needed right now in Missouri in order to address the tremendous need for greater access to the population. Within the state of Missouri also, of the 114 counties, there are 6 counties that do not have a single practicing dentist. Now, we all recognize the impact that oral health has upon one's overall health and consider the ramifications of poor oral health upon an entire community, not to mention the entire state. Think about the physical development of a child who experiences poor oral health. Will they be able to eat properly? Will the appearance of their teeth or the impact of a toothache, will it have an impact upon a child's socialization skills, their behavioral health, and their self-esteem? Also consider the amount of school time missed because a child is unable to attend class due to poor oral health. For adults, will the appearance of their teeth impact their ability to be considered for a job? What is the overall economic impact upon a community from having unemployed citizens or having an employed individual who must miss work because of a toothache or any other health concern? So if you allow me, I'd like to tell you a little bit about the Missouri School of Dentistry and Oral Health, and we will strive at this school to assist the citizens of the state. Through our students, our staff, and our faculty, we will make a strong and positive impact upon the oral and the overall health of the underserved, underinsured, and otherwise disadvantaged populations within the state of Missouri. The Missouri School of Dentistry and Oral Health, or MOSDOH as we affectionately call our school, will train students in comprehensive oral health skills as outlined in ADEA's competencies for the new general dentist. Our coursework and our curriculum are integrative in that courses are taught in the immersion technique with modules which build upon previous coursework, and theme set skills learned in earlier courses set the foundation for subsequent courses taken by the dental students. By sequencing coursework, students start each course with a relatively even base of knowledge on human and dental sciences. Core disciplines and systems courses are taught during time frames of 1 to 3 weeks in duration, and there is, of course, integration of dental as well as medical principles in the design of the curriculum. Most of the human science courses are taught by the faculty from the Kirksville College of Osteopathic Medicine, the medical school which is located directly next door to the dental school. And many of the medical students do their simulation training in the same building that the dental students take their coursework in their dental simulation lab. Medical and dental students have already participated in interprofessional activities, and there are more interprofessional experiences and activities in the planning stages between medical and dental students on this campus. These activities will take place in the communities as well, not just on campus. So interprofessionalism and interprofessional activities are key components to the Missouri School of Dentistry's and Oral Health student education. As I mentioned before, coursework from previous courses set the foundation for courses that follow. Our students not only learn material taught in the courses, but they are able to apply the information, analyze the information, process the information, and develop solutions that will best meet the needs of the patient's family, and the entire community served by the dental students. Faculty at MOSDOH are very supportive of the students, and we encourage students to seek guidance and to offer their thoughts on how to best approach population-based healthcare. I'd like to provide you with a brief overview of the model of the Missouri School of Dentistry and Oral Health. The first and second years of study will be done at the Kirksville campus of A.T. Still University, located once again in Kirksville, Missouri. At this location, didactic and preclinical simulation lab training will be done. At the end of the second year of study, students move to St. Louis. The students will then work in a 92-chair dental clinic that is currently under construction, and they will be at that facility for their entire third year. Grace Hill Health Centers Incorporated, a federally qualified health center, will be responsible for the day-to-day operations of this clinic, while A.T. Still University will be responsible for the overall training and education of the students. During the fourth year of study, the MOSDOH students will perform clinical rotations at other community health center groups around the state. Each rotation will last approximately 4 to 6 weeks, and up to one half of the fourth year will be devoted to these rotations for each student. Dentists at the rotational sites will be ATSU, A.T. Still University adjunct faculty, and these dentists at the rotational sites will be standardized and calibrated with the student assessment criteria used throughout MOSDOH. Having the students serve in community health center settings during the third and fourth years will help to increase access to oral health care services, and it will also help to decrease the oral health disparities experienced by the underserved, underinsured, and otherwise disadvantaged population groups. The 92-chair clinic in St. Louis will allow for the provision of comprehensive dental services. Students will be trained to deliver the entire spectrum of dental care, from prevention services through complex rehabilitative cases. As was mentioned before, the clinical operations will be managed by Grace Hill Health Centers Incorporated, a federally qualified health center. While Grace Hill will be responsible for the daily operations of the clinic, again, A.T. Still University will be responsible for the overall education of the dental students. Third and fourth year dental students will provide care and address the oral health needs of communities in rural as well as urban settings. The Missouri School of Dentistry and Oral Health was granted initial accreditation by the Council on Dental Accreditation in August of 2013. As I previously mentioned, the St. Louis Clinic will have 92 chairs. All of the dental specialties will be represented in the clinic. There will be 6 chairs in the clinic that will be devoted exclusively for urgent care. We will also have a bariatric chair in this facility, as well as provision to accommodate patients that are utilizing a wheelchair.
Dr. Halliday, do you have an idea of what your impact will be on the community?
Yep, thanks, Eugene. That is a great question. Let me show you right here. This slide here demonstrates what we feel how MOSDOH students will have a strong and positive impact upon the population that they will serve. Once we have 2 classes in St. Louis, at the clinic in St. Louis and at rotational sites, we estimate that of those then 84 students, once again in St. Louis and additional rotational sites, those 84 students will have an active patient population of close to 9,400 patients, and we estimate that will deliver approximately 39,000 patient encounters annually. Though accessing patients through accessing patients at community health centers, we also estimate that the 2 classes of students will provide almost 3,300 adult who otherwise do not have dental coverage, with close to 14,000 patient encounters taking place with this adult population. Now, of course, these are estimates, but we feel they're fairly accurate numbers based upon our sister school in Mesa, Arizona. And we once again feel that our dental students during the third and fourth year will make a very strong and positive impact upon populations within the state of Missouri. So this slide here, this is the architect's rendering of what our St. Louis clinic will look like when it's completed next spring. The anticipated completion date is approximately the first week of May of 2015. Students will begin occupying the building by June of 2015. Patient services will commence by July 2015. The building, as you can see in the picture here, will be 3 levels, a total of about 79,000 square feet. The dental clinic will occupy the first 2 floors, and the third floor initially will be unoccupied. The university, the board of trustees, and the president of the university are speaking with community groups as well as partner groups throughout Missouri about possibilities for use of the third floor, whether that be for dental or for medical purposes. So it'll be very exciting to see what happens within this building, but I envision interprofessional activities between dental and medical and other health professionals taking place in this building. This is actually a picture that was taken about 2 weeks ago. The building is now about 40% complete. Since this picture was taken, the entire exterior precast siding has been put into place. Of course, all the steel work is done, and the building company has started working on the interior of the building. Once again, 92 chairs, and we think we're going to make a very strong and positive impact on the populations, not only in St. Louis, but throughout the state. So thank you all for allowing me to tell MOSDOH's story, and Eugene, I'll turn it back to you.
Thank you, Dr. Holliday. One quick question. Are the dental students at MOSDOH educated with dental hygienists?
At this time, they are not. Now, we have had contact with some of the dental hygiene training programs in the state who would like to have our students do some training together, and that's certainly something that we'll consider.
All right, thank you. One of the questions that we received was regarding loan forgiveness programs and various repayment options, and the question about what kinds of programs exist. There are a variety of different programs available to students, and one of the resources we recently provided here at ADEA is a link to those resources state by state, and so we just posted in the chat box the link to that information. If that link doesn't work for you, go to the ADEA website and you should be able to find that information. So we'll try to make sure also that we include that link in the PDF of the presentation. So I want to ask one last question of all 3 of our experts and then turn our remaining time over for additional questions from our audience. And the final question is, what can our members, those listening, do to improve the dental safety net? Let's start back again with Dr. Lemperis.
Sure, Gene. What I'd suggest that all dental schools do, if they don't already have one, they should develop a really vibrant community-based service learning program. Something we've been doing here at UNC for, goodness, over 50 years. The program, called Dentistry and Service to Communities, requires that all of our rising D4s spend at least 8 weeks during the summer between their 3rd and 4th years providing care in community-based settings, be they local health departments, federally qualified health centers, correctional institutions, IHS clinics. What this really does, though, is it prepares our students to witness that disproportionate burden of disease, oral disease that's manifest in our nation's most vulnerable populations. And they develop an experiential understanding of the environmental and social issues that impact an individual's health. Of course, their clinical skills are honed, but I think of equal, if greater importance, is that ethical obligation to serve a greater good is cultivated. Since I've come here at UNC, I've been here maybe about 14 months. I've gone to I've done about 36 site visits throughout the state where our students go out to have their DISC experiences. And I haven't collected the data, so it's anecdotal, but over and over again, what I'm finding is our graduates are now working in these community-based sites, and they've chosen to do so based on their experiences with DISC. It's very heartening to go out there and find this. So a really strong program that gets students out for a significant period of time while they're training into community-based settings like we are doing here at UNC is something that I would certainly say that our academic institutions could implement if they don't already have one to improve that dental safety net. Just an idea.
All right. Dr. Lucas Perry, what can our members do to help improve the dental safety net?
Sure. So I think the biggest thing that our members can do is really advocate. Advocate on their local level and then also on the federal level for increased access to care. So that would be in the form of expansion of Medicaid. And then also, I think it's important to note that the National Institute of Dental and Craniofacial Research, NIDCR, has a lot of research that is focused on underserved and vulnerable populations, the aging populations, different medical problems that specific underserved populations face. So I think advocating for increased expansion of coverage and also research. The other one that was just asked by one of our members in the chat room was at a nonprofit that's not necessarily oral health related. How can they be involved? And that then goes towards, I think, collaborating here at ADEA, at other organizations, and even our academic dental institutions. We're always looking for opportunities to increase the knowledge and the perception of the importance of oral health. And so I would say it's just really reaching out to those groups.
Thank you. Dr. Halliday, any quick words of advice for our listeners?
Sure. Thanks, Eugene. I'd like to build upon Dr. Lampiris' statement, but in addition, I'd like to ask the folks out there to involve your students, involve your dental students in the design of the community-based activities. I know this is going to sound a bit corny, but this is my first foray into academia, and I am really impressed by this generation of young folks. I mean, I think this generation gets it. They understand it. They're altruistic, and they want to help. I've involved my students here very much in the design of community-based activities. They do a fantastic job at doing it, and I think they understand what communities need. And real quickly, Eugene, I'd just like to add also I'd like all of us to encourage our students to act as role models when they're out in the communities. A lot of the young folks in these communities haven't had role models, especially in the underserved population groups, and it'd be nice if our dental students would be role models to impress upon these young folks that, hey, someday I could be a dentist too. And in this real quickly, one other thing is I'd encourage everyone to network with their local community health centers if you do have one in your vicinity, and also with the state primary care associations. They're eager for partnerships with healthcare institutions, so I strongly encourage people to do this. And also involvement with community health centers will help to satisfy Institute of Medicine's recommendation for involving our students in community-based activities and delivering care in community-based settings. Thank you.
Thank you, Dr. Halliday. So we have a few questions floating around from our participants. The great thing about this open chat is it allows participants to provide their own insight and perspective. So there's a bit of a chat discussion going on. So let me just pull out a few questions to pose to our expert panel. So the first question is, how can dental school graduates be encouraged to provide more care to underserved populations?
Well, Gene, this is Lou. I think Dr. Halliday said something about the students. I, too, am kind of new in academia, but I've seen this commitment to service in students that are in our school right now. So, again, setting up programs to afford the students to get out into communities and to see the need and provide care is a powerful, powerful motivator.
The other point I'd like to make, Dr. Anderson, is really, as we mentioned and we put in the chat about the scholarships and loan repayment program, it's educating our students about those opportunities. But again, that's really the role of the extramural clinical rotations, is to get the students familiar with these communities, understanding the needs, and letting them know that how they can be culturally competent. And so I think that's one of the main ways, is really the exposure and then, of course, the education of opportunities after they graduate.
Yeah, and Dr. Anderson, I would chime in once again stating, by allowing the students to have this opportunity to work within the communities, I think it will, on a lot of students, it will raise their awareness, and those that are already aware, I think it will heighten their awareness of the needs of these populations. And once again, I keep harking back to IOM, but I think that I agree with IOM that having the students involved in the community will raise the possibility that some of the graduates, upon graduation, will go on and consider either careers or spending time in community-based clinics.
Thank you. Another question posed by several of our participants relates to the potential role of dental therapists and other newly proposed workforce models such as community health coordinators. So any thoughts on the impact of some of these new workforce models might be on the access to care issue?
Well, as I said earlier, Gene, HRSA has clearly defined that there are some significant issues regarding the distribution of dentists throughout the country, especially if you look at those health professional shortage areas. So I believe that what's going on in terms of developing these different models that are out there are very valuable and can make a difference in improving access to care for underserved populations. Certainly, that's been shown with what's gone on with the CDHCs, the ADEA has developed with the mental health aid therapists that have been developed in Alaska and Minnesota. So, yeah, they can play a role.
I also want to say, Dr. Anderson, is, it's important to look at this as complex as it really is. And so while workforce does need to be addressed, when it comes to accessing healthcare, oral health care, it's really a comprehensive picture that needs to be taken into account. And so the workforce is an issue, but the patient education is an issue. Like I said, provider competency is an issue. So there's a multitude of different factors that need to be addressed in order to eliminate the barriers to oral health care.
And Dr. Anderson, I'm supportive of having as many resources as possible for our educational activities and our treatment activities getting to populations. So, and I think a resource which often isn't utilized are the additional healthcare providers. I have always found, with my experience with the Indian Health Service and elsewhere within the Public Health Service, that pediatricians and physicians in general and the nurses are just tremendous resources. So I'm all in favor of expanding our circle of resources in order to get the message out to communities.
Thank you. Well, I'd like to thank each of our speakers for giving us their time and their expertise today on this very important topic. Drs. Lampiris, Lucas Perry, and Holliday, thank you for being with us. I also want to thank everyone out there from across the country and around the globe who has been listening to us this past hour. And before I turn over to Kurt, I'd like to tell you about our next webinar. If by chance you've been living under a rock, you may have missed the fact that we have a very important election in this country next week. And certainly there are implications for this topic and healthcare reform in terms of what happens in that election. So we have decided to push back what would be a November webinar to Tuesday, December 9th, starting at noon Eastern, where we will explore the Affordable Care Act, healthcare reform, a post-election assessment. Hopefully, by that date, all the results will be in, and we will know just what direction we're headed in. So with that, I thank you all, and turn it over to Kurt. He will give you details about the evaluation and how to obtain your CE credit. Thank you.
Thank you, Dr. Anderson. That does conclude today's presentation, The Dental Safety Net and Access to Oral Health, brought to you by ADEA and presented by Christopher Halliday, Lou Lampiris, and Evelyn Lucas-Perry. Your ADEA host was Eugene Anderson. We do hope everyone enjoyed the presentation. CE is available for this presentation, as was mentioned. To obtain CE, you'll need to enter your name in the site roster. You will receive an automated email with a link to the evaluation and a link to the certificate manager. Completing the evaluation form, and following that, you will then be able to retrieve your certificate. We also recommend you be sure to follow ADEA Web on Twitter to join the conversation, and that hashtag for this presentation is Dental Safety Net. And you can find a recording of today's presentation of the program at www.adea.org/Dental Safety Net. That will be posted 1 week from today. Today's program is copyright in 2014 by the American Dental Education Association, all rights reserved. Thank you all for joining us today, and enjoy the rest of your day. The evaluation will appear now.